Hello, and welcome to Wellness Wednesday Palliative Care Series, Making Sense of It All. I'm Krista Ellis, Community Engagement Manager for the Parkinson's Foundation. Helping me behind the scenes are my colleagues Jenny Fearday and Jennifer DeGruccio. We warmly welcome you to the webinar today, especially anyone joining us for the first time. Today, we're stepping into the second session of our palliative care series. We will learn about common emotions that people with Parkinson's and their care partners might experience and when to seek a higher level of support. We will also discuss how to spiritually add meaning to your life and how the role of a chaplain can help support you emotionally and spiritually. Following the presentation, we will have a live Q&A session, and we hope that you will join us for all of our palliative care sessions. Please note that we are recording today's presentation, and you will receive a follow-up email from us with a link in today's recording and our slides. As we begin, we want to welcome you and take a moment to share the mission of the Parkinson's Foundation. Every day and in everything we do, we are working to make life better for people with Parkinson's. Today, we have representation of our Parkinson's disease community across the globe. 8 countries, including the United States, Canada, the UK, Italy, Australia, Ghana, Costa Rica, and the small little island off the coast, Mauritius. 39% of our participants today are people living with Parkinson's disease. 36% of our participants are care partners. 10% of those joining us are adult children with a parent who has Parkinson's disease. And 15% of our participants are healthcare professionals or identified as another connection to Parkinson's. To achieve the mission of the Parkinson's Foundation, we pursue 3 goals: improve care for everyone with Parkinson's, advance research toward a cure, and empower and educate our global community. Today's program is a great example of one of the things we're doing to help us meet these goals. One example of our mission in action is PD generation. This research offers genetic testing for PD-related genes and genetic counseling to people with Parkinson's at no cost. Commit to helping us advance Parkinson's research today. You can check your eligibility and enroll now to be a part of PD Generation at parkinson.org/PD Generation. We'd like to take this moment to thank PCORI, a patient-centered outcomes research institute, for their implementation award to support our palliative care series. Thank you, PCORI, for your generous support. If you're looking to get involved, we're excited to share our initiative meant to capture the community's perspective on various topics in Parkinson's disease. We hope that you'll join us by signing up for this initiative, where we invite you to complete a 10 to 15-minute survey on various topics such as mental health, telehealth, and care partners. We will always report our findings back to the community. You can learn more at parkinson.org/PF surveys. And now I am pleased to introduce our speaker for today, Dr. Sue Ouellette, Sue, as she is a chaplain and the Neurology Supportive and Palliative Care for the University of Rochester Medical Center. She also holds a secondary appointment there as an assistant professor in neurology. And she has a PhD in communication from Kent State University, as well as an MA and M.Div degree. She's also a licensed marriage and family therapist and an ordained deacon in the Episcopal Church. Sue taught at the University of Arkansas and Northern Illinois University and chaired the School of Allied Health at the latter institution. She directed a national federally funded research center at Northern Illinois University and served as the director of research at a similar center at the University of Arkansas. Most of Sue's research centered on improving vocational and social outcomes for persons who are deaf or hard of hearing. She holds the rank of Professor Emeritus at Northern Illinois University, has presented internationally, and has authored numerous publications. Please join me in welcoming Dr. Sue Ouellette.
Thank you so much, Krista, for that lovely introduction. I am so very glad to be here with you today. I would like to take just a moment to share my screen. If you'll go. Okay, and to talk about just some basic concepts, and I am very eager to hear your responses and your comments on it. So my focus today will be on emotional and spiritual challenges that are associated with Parkinson's disease, looking at this particularly from a caregiver's perspective, but welcoming all the perspectives that are available today. So looking at the emotional side of things first, I'd like to talk about a concept that to me is at the center of understanding Parkinson's disease from an emotional perspective. And that's the concept of grief and loss. Grief and loss are emotions that occur not only when you lose someone, but also when you lose things that are important to you. And this includes what I would call core level dreams. The dreams that all of us have for what our lives will be like. The dream of growing up and having a family and a job and being a parent. The dreams that we have for our later years of what they will be like, where we will travel to, how our retirement will unfold. Many of these dreams are shattered when there is core level loss. And that happens very frequently in chronic illnesses like Parkinson's disease. So the concept of loss, of losing abilities, losing relationships is core to me in understanding Parkinson's disease. Grief is a normal, natural, and actually a helpful process that allows us to sort through what is happening in our lives and to begin to make sense out of it. I had a colleague who wrote about grief, and he said it's as if all the dreams that you had for this stage of your life have been shattered, and you are wandering in a dreamless void with no dreams at all until you can begin to attach to some new dreams that fit with the reality of the situation that you find yourself in. The losses associated with Parkinson's begin at the time of diagnosis, and they're so familiar to so many of you. The loss of the ability to drive, the loss of independence, the loss of agency in so many ways, and so many other things. I think it's important to point out that these losses are experienced by patients, certainly, but they are also experienced by caregivers and family members. They too have dreams for what life would look like at this point, and their dreams have also been shattered. So I think it's important whenever we talk about loss to realize that it's very much distributed through the family and through those who care about the person with chronic illness, in this case, Parkinson's disease. The natural tendency that we have as human beings is to try to fix things. If you've ever attended a funeral like calling hours or something like that, you've undoubtedly heard well-meaning people say to the bereaved things like, well, at least he's not in pain now. Things will be better for you now. You'll get over this and move on. Those are all our attempts to make ourselves feel better by saying something useful. And as heartfelt as these messages might be, there's still attempts to change the situation. When we can meet people where they are emotionally and enter into their reality and what they're feeling, it can be so much more therapeutic, but it can also be so much richer in terms of building relationships. So if I see a patient who's crying, instead of hitting him Kleenexes or saying, "Oh, cheer up, it'll get better," I might want to go to them and say, "I see that you're sad. Can you tell me a little bit about what you're feeling right now?" And then really just be present to listen. Many people feel like that doesn't feel like enough, but it really is enough. It really is what all of us need when we're in that place. Common emotions associated with Parkinson's disease. I'm sure all of you are aware at one level or another that depression and anxiety may be present. Perhaps we might even say are frequently present. I think it's very important, though, to separate the normal anxiety that is a part of the grief process from clinical depression and clinically significant anxiety. They may be present, and it is very possible that what we're seeing instead of true depression is grief. Grief has no particular pattern, despite what you might have heard, or if you've ever taken a course in which the work of Dr. Kubler-Ross was discussed. There are models of grief that have been proposed, and they have nice little graphs and patterns of how you should grieve. I have a slide in one of my presentation decks that follows that nice orderly graph of grief with a picture of a graph that just has random dots all over it. And it says how I grieve. The first one, how I'm supposed to grieve, and the second one, how I grieve. In reality, we don't follow a pattern. We might be angry one minute, we might be anxious the next, we might be very sad the next. And then we might be right back to a period of denial. And by the way, denial is not a bad thing. We talk about trying to help people through denial. It's not going to stay there forever. That's true. But denial is the safe place that we go to when something overwhelms us so much that we don't have the resources to deal with it. So that buffer that we get for just a little while gives us time to figure out what's out there, what can I reach for, what will help me to get through this, and it's valuable. I think guilt is a almost universal emotion that's associated with Parkinson's disease on both the part of the patient and the part of the caregiver often. For the patient, it may be guilt that the caregiver has to do so much, that the loved one is so much on his or her shoulders, and the feeling of helplessness of not being able to do more to alleviate that burden. On the caregiver's part, it's often guilt. Am I doing enough? Do I know enough? Am I strong enough? Can I give my beloved what they need? So again, just realizing that this is extremely common, that many people experience it, being able to talk with people about it, being able to talk with each other about it is so helpful. I mentioned that anger is a common emotion that arises. And again, both in the patient and the care partners, we all have our limits. And when we are pushed beyond them for whatever reason, we may turn to anger as a way of making sense out of justice. Anger lets us struggle with, how is this just? How is this right? How is this fair? And those are extremely important questions that we struggle with in light of chronic illness of any kind. Next one, motivation loss or apathy is something that I very commonly hear, either from family members who say, oh, I just can't get my loved one motivated enough to do much of anything. He just wants to sit and watch television all day or stare out the window. I also have heard comments about just not being able to get motivated from patients, just feeling like they really don't care that much, or don't have the motivation to do the things that they need to do. Some of that is grief and loss. When you have lost everything, or it feels like you have to you, it's easy to lose motivation as well. But some of that is also Parkinson's disease. And it's important to remember that what you're seeing as apathy may be a result of the disease and not a choice of the person who is exhibiting it. That can help us to be a little more charitable towards a person with that particular symptom, and realize that we want to encourage them as much as we can. And yet there may be factors beyond our control that we need to take into consideration when we think about how it affects each of us. And the effect is very real. I don't mean to minimize that in any way. For family members, care partners, those who care about the individual, they too have very definite feelings about the lack of motivation and what it signals to them or means. It's a struggle for many people. And I will sound like a broken record, but you'll hear this again. Our instinct is, what do we do with it? There's guilt, there's anger, there's apathy, there's anxiety, there's depression. The first thing we do have to do is to figure out, is this real depression? Is this more demoralization just from the grief process? Is this true anxiety? Or maybe it's experiencing off times in a way that the person feels quite vulnerable. And all those factors have to be taken into consideration before a diagnosis is made. Having access to a mental health professional who understands neurological illnesses and Parkinson's in particular is really helpful. If you don't have that, sometimes it's a matter of putting together a team that can inform each other in a way that the sum of everyone's knowledge is greater than the limits of any one person's knowledge and experience. So no need to fix those emotions. They can be treated. I think it's important to say that. There are medications that help a lot with depression and anxiety. There are therapy techniques. They're very effective with depression and anxiety, and which are evidence-based and have been researched thoroughly. So the task is to figure out an appropriate diagnosis and then to develop a treatment strategy based on it. Speaking specifically on caregiver burnout and stress, I think one of the first things that's important is to say that most of our literature is about burnout and stress. There are also joys of caregiving, and I think it's really important to note that. there's growth to be had through the experience for both the patient and the care partners. Although our literature is very heavy with the burnout and stress side of things, one of my colleagues, Dr. Shashadri, is studying the positive aspects of caregiving and the benefits. So I say that as kind of a frame for everything else that I'm about to say. Certainly, self-care is absolutely critical if you are a care partner, and that's almost too simplistic to even begin to address the issue. You're busy every minute of the day. How do you find time for yourself? What are some brief strategies that you might be able to implement? And there have been some good things written about this. I know there's a study at the University of Rochester right now that is looking at the best way to provide instruction in self-care skills. Kristen Neff, Neff, is a person who's written a great deal about self-care, not specifically for caregivers, but she has some very nice information. I'll make this available if anybody wants a particular reference. I think besides self-care, other care, care of people who understand what you're going through is really important. So the informal kinds of support, peer groups are very helpful. Perhaps you belong to several support groups at the national level, certainly local levels, specialized support groups for things like young onset or women with PD. Peer mentoring too, the connection of a caregiver with other caregivers, something we do at University of Rochester that has worked very well. And I know it's a common practice in other areas. On a more formal level, receiving therapy, sometimes called counseling, or psychiatric treatment is certainly an option if you are noticing signs of depression and anxiety, if you are not able to cope and are feeling very overwhelmed. They can be extremely, extremely helpful. The psychiatrist is the medical doctor, M.D, who has extra training in mental health and psychiatry. She or he is often the person who prescribes the medications if they're needed. Psychologists are usually PhDs, and they do a great deal of assessment and testing, and may also do therapy. Therapists come in all kinds of stripes and colors. There are social workers, licensed clinical social workers. As I said, some psychologists provide that service, marriage and family therapists, licensed mental health counselors. They might be called licensed clinical counselors in some states. You will know them by their licensure. And as I mentioned before, finding someone who has some understanding of neurological illnesses is helpful. So how do you know when you or your loved one needs professional assistance? Certainly, if either of you are at the point where life feels completely unmanageable, that's an important sign. Any cry for help in the term of suicidal ideation, thinking about maybe hurting themselves, is a good sign that you would want to have a professional assessment Oops, excuse me, I did not mean to hit that. Back up. I think, in my opinion, it's always better if you have a question to check in with a licensed professional. He or she may say, you know what, I think you're doing just fine. Your support group is a wonderful backup for you, and you're doing a good job with self-care, you're fine. Or might say about a patient, you know, this is pretty normal grief stuff. We just need to find some ways to express it. But if it is something that requires medication or treatment, the professional would be able to guide you to places and professionals who could help with that. So I would always err on the side of seeking professional input. Okay, and this just kind of restates a few of those things. What kind of help do you need? Do you need a diagnosis for the emotional part of the thing, assessment, medication? I see a lot of couples for therapy because the relationship changes, right? Husband and wife can start to morph into patient and caregiver. And very often working on communication, how you ask for things, how you express your feelings, can be extremely helpful. And I talked about the kinds of professionals already. One of the big questions is always insurance coverage, whether or not the provider accepts insurance, and also whether your insurance covers the particular type of care that you need. And then availability. Everybody's been busy since the pandemic. So can you find somebody that will really help with that? I want to move along quickly here to talk a bit about spiritual needs and challenges, because I want to leave lots of time for Q&A afterwards. So I'll take off my therapist hat and put on my chaplain's hat, and we'll talk a little bit about how important it is to include the spiritual needs along with the emotional and physical needs of each individual. So when we talk about spirituality, we are not necessarily talking about religion. Spirituality is about making meaning. How do you figure out what things mean? How do you come to grips with the rationale or lack of rationality of what's happening? A particular religious orientation is more likely to be represented by clergy in that faith tradition than it is by chaplains, for example. We'll talk about the role of the chaplain in just a minute. So not necessarily concerned with religion, but concerned with making meaning and figuring out the whys. Why did this happen to me? Where's the fairness in this? Where's the justice? These are the big existential questions that we have in life. And they are all triggered when we face a chronic and progressive illness like Parkinson's. Jumping down to the point about joy, awe, and wonder and hope, I think it's important to note that spirituality does not just include the struggles with making meaning and figuring out the whys, but also how do we find joy in the midst of dealing with this illness? Life is not what we thought it was going to be. Is there joy to be had somewhere along the way? And how can we maximize that? Awe and wonder, that incredible feeling we have when we look at something beautiful. And whereas once we might have looked at beautiful things after hiking to the top of a tall mountain, Maybe now it's just pictures or looking through a beautiful book or watching a video, finding some way of bringing that beauty into our lives. And hope, we all have to have hope. And with a progressive illness, hope becomes a hope for tomorrow and the next day. It might not be that hope for 20 years from now, because we don't know what the disease will do in that period of time. It's often on a shorter path, but there still has to be hope. Hope for a good day tomorrow. Hope for time to spend together. Hope for joy. Spiritual support is provided by spiritual care professionals. They are credentialed by Association for Professional Chaplains, APC. They have at least a master's degree. Most do a 2-year residency on top of that. They have been trained specifically to provide the services that they do. And what does a chaplain do? So a chaplain should be able to assess spiritual need and develop a treatment plan, just like a therapist would or a physician would. There are assessment measures that can be used that will guide that process. We look for specific patterns like spiritual distress, which might occur when people have one belief and yet what they're seeing is something different. A very common one that I hear is, I have a belief in a higher power as a loving presence. How would a loving presence give this disease to me? It's a big question. In fact, so big that a rabbi wrote an entire book on the subject back in the 80s, I think, that was called When Bad Things Happen to Good People. He struggles with that question back and forth. Chaplains don't necessarily talk about religion at all. In fact, we call in ordained clergy from various faith traditions when that is needed. But we will sit there and struggle with you through these questions. We may not have all the answers, but we will struggle with you, meet you where you are at with it, not criticize you for having questions and doubts. As I said, we may call in clergy or others from specific religious traditions to assist. And we want to help patients clarify their values regarding such things as the illness itself, treatment, and certainly end of life being something that we have conversations about as early as possible, so that the values of the family, the wishes of the patient can all be followed. And as I said, we look at things like spiritual distress. I think that's my last slide today. I guess what I would want you to take away from all of this would be, first of all, that grief and loss are normal, natural responses to the many losses associated with Parkinson, and they're experienced by all members of the family, the care partner, and the patient. Secondly, I'd like you to take away that people with Parkinson's can experience anxiety and depression or demoralization without having mental illness. But like anyone, people with Parkinson's can develop mental illness. So differentiation is important. Third, I'd like you to remember that the stress of caring for somebody with Parkinson's is substantial. Caregivers can experience fatigue and a variety of emotions like guilt and anger and sadness and joy. Support is available to you. You please use it. And lastly, fourth point I'd like you to take is that spirituality involves how we make meaning out of what's happening. It may or may not include religion, and chaplains may be a resource that you would want to reach out to for support in that very important area of life. And with that, I am going to end and hand it back to Krista and invite your comments and your questions.
Thank you, Dr. Ouellette. Jennifer, if you would stop her share screen, please. Today, we are welcoming, following the presentation from you, Dr. Ouellette, thank you so much, a care partner to join in the dialogue with us. I welcome Clarice Jackson. She's joining us to share her experiences as a care partner. And she was a care partner to her husband, who was a pastor for over 40 years. She's also a licensed professional counselor and currently facilitating online care partner anticipatory grief and bereavement support groups designed specifically for our care partners affected with Parkinson's disease. Clarice, wherever you are, come and join us. There you are. Thank you so much for being with us today.
Thank you for having me.
A question to follow up from your presentation, Dr. Ouellette. You discussed the meaning of spirituality, and I think for a lot of our community, there's a fine line between religion and spirituality. And I'm just wondering if you could offer our community some examples of spiritual practices that aren't necessarily associated to religion.
Yeah, sure, I'd be happy to. I think of the spiritual experience as being out in nature and connecting with the wonder of the creation of this world. A spiritual experience can be with someone in a very special moment that has nothing to do with religion at all, but just sharing heart to heart, a connection that helps you to realize that you're not alone.
Mm-hmm.
Those are examples of spiritual connections.
Clarissa, I'm sorry, I keep saying your name so wrong.
It's all right. It's Clarice.
Thank you, Clarice. Do you have anything to add as far as examples outside of religion that can connect us more spiritually?
I agree with Dr. Ouellette. When you were talking, Dr. Ouellette, something came to my mind when you talked about bringing hope and joy into the day. And I thought of a time when my husband has passed, but when he was very ill at the very end, and I would get him up every morning and get him dressed. And he had a great sense of humor. Although I couldn't understand him, his speech was really bad at that level. So he would ramble off something and start laughing. We both would just start laughing. That's joy in the midst of, and that's spiritual. That's a deep spiritual connection.
Yeah.
Beautiful example.
Absolutely. Yes, Clarice, thank you so much for sharing that.
Mm-hmm.
What are your feelings as far as a spiritual practice, not necessarily religious practice, but spiritual, yoga or meditation, journaling, volunteering, and again, coming back to connection with nature?
So are you asking me what I think how those things could help? Yeah.
Mm-hmm.
Okay. Yes, definitely journaling. I am an avid journalist, and I literally go back and am reading now my journals from a year ago. And
Wow.
when I'm upcoming to my husband's 1 year being gone, and very helpful, a good way to able to put your feelings on paper and not keep them bottled up, and then you can process them. I like computers, I like phones, but I say use your hand and a pen, write it, because there's a connection between writing and the feeling and releasing the feeling. Meditation is wonderful. I think if you can get outside even for a few minutes, sit on the porch, listen to the birds, take your dog for a walk, for all those things, and then whatever other spiritual practices you have to engage, to incorporate those into your everyday life so that they can be very supportive and helpful.
Thanks, Clarice. Dr. Ouellette, we received a question from Barb and Dale. They're asking if you could talk for a few moments about wearables for a patient to call for help when they're alone. There's many online. Just what's your opinion about these wearable fitness trackers or watches, kind of call for help tools? What would be your opinion about those?
I think when people are alone for any length of time, that it's really important for all of us to have some way of getting help. Current technology has helped us so much in that the Alexa, or whatever brand of that you
I
have,
know everyone's Alexa's going off now.
right? Sorry about that. Can call anyone that you want, so you can simply say, blank, call my daughter, or call 911. The watches. The Apple Watch has a fall signal on it, and I found out it really does call for help if you don't answer it. So the popularization of these devices has been really nice. The more sophisticated wearables that are tied into a 911 service are really the gold standard there, and it's just important to have some way to ask for help. I'm all for.
Thanks, Sue. Clarice, I'm curious, and so are our participants. How do we stay positive? They wrote in, how can we build a capacity to adjust to these challenging circumstances? How do I keep positive?
Oh boy, I wish I had a magic wand, because that's a hard thing, because this is an overwhelming, Parkinson's is an overwhelming disease for both the patient and the caregiver. I think that you're building your support system is huge. Having a group of people that you can collectively bring around you, family, getting the family in. For me, my faith was absolutely integral in being able to plow through. I say that Parkinson's is a thief. And from the moment you hear Parkinson's, it starts taking from you, taking from your life, taking from the patient's life, the caregiver's life. So any way you can add to. So if you could, like Mike lost the ability to walk without falling. So we got a wheelchair that was easy to move outside, and we would go for walks. Sometimes he had very little interest in, but it was still good to get him outside. And that helped me, though. That gave me a break as well. So any way you can integrate, those things, but and calling upon your professionals, the palliative team, hospice teams, to really, close in and close those gaps, where we give you some ideas, because often you're overwhelmed and cannot come up with some solutions or some helpful things. But it is possible. It's very, very challenging.
If I could add just one thing, maybe it's not a reasonable goal to always be positive. This is tough, really tough stuff. And sometimes you're going to struggle, and giving yourself that grace, that permission to not always be positive can be really helpful too.
Yes, thanks. Thank you both for your opinion on the matter. And the foundation, we've been working hard to recognize that there's this culture of positivity, right? And in Parkinson's disease, it is hard. It can be very heavy. And there's lots of room for embracing challenges, but there also needs to be permission to just let it be heavy and hard sometimes, and to process those emotions. So I appreciate you, Dr. Ouellette, for giving us permission to not be positive all the time. Another question that we have from our participants is thinking about strategies to improve our physical, mental, and just overall emotional well-being. I'll start with you, Clarice. If you have any, tips or trades that you learned in your times care giving for your husband, what you did as a care partner for yourself, not for Mike, but for you, to maintain your own well-being.
Yes. So I am a therapist, but I absolutely maintain a relationship with my own therapist and have throughout the last 4 to 5 years. So I think that's very integral, someone that can follow you through the process. And so you don't have to explain it every time. They understand what's going on. Exercise. I will not move any place without my treadmill. And I have to have a treadmill, and I have to walk. And I also have 2 little dogs. One of them was my husband's dog, and now I have another dog. They help get me up in the morning, and they did when Mike was alive. They bring joy and just fun, but also not isolating. I'm an introvert, so I tend to isolate. So trying to really be careful not to, when I had an opportunity to get out with people, and even throughout the grief and bereavement period, not pressuring myself or forcing myself, but really encouraging myself to say, just try this, just see if it will be better. You may like it. It may be, helpful to you. So not isolating. And then again, drawing upon whatever spiritual beliefs you have, those deep inner, where your life comes from, where your meaning comes from, to draw upon those things, but also take on, if you can eke out a few minutes to maybe learn how to knit or do some painting, something you could do from home, with your care partner, with your partner there. So you could have a camera in another room watching so that they're okay and safe. But, doing those are the things that helped me through.
Great. Thanks, Clarice. Dr. Ouellette, do you have any suggestions to add?
I am of all of Clarissa's suggestions are wonderful. I would agree with every one of them. I have a favorite practice that I often introduce to the people I work with, and it's a very simple meditation practice. It's mindfulness-based stress reduction. It's a breath meditation that can be learned in literally 5 minutes. It doesn't have any religious significance or anything that would feel restrictive. It's simply training your brain to do what you want it to do. And it's very relaxing, I think very centering. So I do encourage people to try a meditation practice. If they don't like it, that's okay. I think yoga is great. I practice it myself. I agree with the exercise thing that Clarice brought up 100%. And journaling, which you mentioned, I think is very, very helpful. So a few of the things that will be at the top of my list.
That's great. And I love that you mentioned mindfulness as an option to really cultivate personal awareness, right? And space just for you to check in. The Parkinson's Foundation hosts Mindfulness Mondays every Monday. So for those of you who are tuning in and are inspired to try some mindful meditation, you can join a Parkinson's community. It's About 50% of our participants are people with Parkinson's, and the other is care partners or loved ones or adult children living with a parent with Parkinson's disease. So there's a community out there for us to practice together. I also really want to point out the point that you made, Clarice, about trying something new, right? Or maybe not trying something new, but revisiting hobbies that you really enjoyed and didn't have time for in the time that you dedicated in caregiving for Mike. So the knitting, coming back to the things that we used to love to do, right? That's something my therapist has encouraged me to revisit, is what brought me joy when I was in college. And those things were, taking a walk, riding my bike, swinging on a swing set. So just some examples that come from my personal life. So I appreciate you highlighting that, Clarice. You mentioned a support group and getting connected in your local community, whether that's in person and or online. So David asks, how did you find a support group and how was it helpful for you, Clarice?
I started going to a caregiver group through the University of Colorado at Anschutz, and I don't honestly remember how I got connected up with it, but it was an amazing group, and and not just people with Parkinson's, caregivers with caregiving Parkinson's, but also with Alzheimer's, other neurological issues. So it was, all comprehensive. But that was amazing. And again, I can't tell you how I got hooked up, but I'm sure if you contacted University of Colorado, you could. And right now, I actually started my own group, having gone through the anticipatory group and the bereavement group. But you can find grief groups all over. You can find support groups all over. And honestly, this is where your therapist could come in handy too, because sometimes you'll say, oh yeah, go find a group, and you're going, oh, I don't have time. I can't even think about looking for a group. But your therapist can also often help you, give you some ideas on where to find a good support group. So I, don't hesitate to. Also, doctors' offices often will have a list of those as well. But they're very supportive and I believe integral to what we need.
Thanks, Clarice. Dr. Ouellette, did you have anything to add?
No, I think Clarice covered it beautifully.
If you are looking for a support group and getting connected with your community locally and or online, you can reach out to the Parkinson's Foundation's helpline. We can be a vital resource in connecting you with local support groups, wellness groups, physicians in the area. That number is 1-800-4-PD-INFO, and one of my colleagues will drop that number numerically in the chat. Dr. Ouellette, Carmelita writes us and asks, can you comment on the value of palliative care or hospice care early in the care plan? When is it appropriate to begin planning ahead?
I think it's always appropriate to bring in palliative services with any progressive long-standing illness. Palliative, I think, is misunderstood by the general community. People think of palliative as end of life. I actually looked up where the etymology of the word came from, and it was from a cape that they used to wear in medieval or pre-medieval times that was like a wraparound blanket, and it's extra support that's there for you. So palliative care looks at symptom management. It looks at quality of life. And now we have a new version of that. We have neuropalliative care that is specific to taking care of families that have been touched by neurological illnesses like Parkinson's. So whether it's general palliative care, specific neuropalliative care, just in symptom management and planning, it can be so helpful. Palliative care providers can give you a roadmap of what to expect in the future. They can help with advanced directives, all of those things. So I'm a big proponent.
Clarice, can you share at what point you decided to seek additional support through a palliative care or advanced care planning?
Mhm.
Mike?
Yes, it was probably a couple of years before he passed, and his complications were getting more and more. We were constantly going to doctors, and the palliative people were able to kind of pull things together for us so that we had like one place we could kind of always go and get help, and so that was helpful to us. And then and it helped also when COVID came about. We were able to do video sessions with our palliative team as well. And then palliative team helped us go from palliative to hospice. And Mike was on hospice for 7 months, and it was the best thing for us. I mean, for me and him. We got all of his care in home, so we didn't have to try to get him in a car and go. And that was stressful for both of us, and provided all the care. And also, I love the fact that Dr. Ouellette, that you mentioned, kind of giving us a roadmap of what's things to expect and to look for, which we had no clue. And that was so helpful. But just very kind, compassionate people, especially the chaplains, were wonderful, just wonderful. And so I hope that answered your question.
And wrapping up for, final statements on palliative care, support from a spiritual guidance counselor, if you will, chaplain, may it be. Dr. Ouellette, I'll ask you if you could share some final words of wisdom with our community here, and then Clarice, I'll have you share your moment too.
I think just the recognition that this is a really difficult disease and a really difficult time for everyone who is involved with it. It takes lots of grace. It takes lots of support. It takes lots of reaching out for any and all resources. But don't forget yourselves, and don't forget that there is joy, there is opportunity for beauty, and make sure that that's a part of your experience as well.
Yeah, those statements just feel like a deep breath and a warm blanket, right? Great. Thank you, Dr. Ouellette. Clarice?
I agree. Very, very challenging for both patient and partner. I guess what I'd like to say is, don't ever hesitate to ask a question. There's never a dumb or stupid question. They're all very valid. And on the days when you get up and you don't feel hopeful, you don't feel happy, you don't feel at peace, give it a moment, give it an hour, and often it will come. And I also be gentle with yourself. I totally agree with that. We can get very overwhelmed and get easily irritated. It is what it is. Apologize and then move on.
Be gentle with yourself. Oh, I'm going to write that one down. Thanks, Clarice. Dr. Ouellette and Clarice, thank you both so much for sharing your time with us today. We sincerely appreciate all that you offer in guiding us through this journey and navigation of Parkinson's disease. And many thanks to all of you who joined us today. A follow-up email will be sent with a survey. Please tell us what you thought about today's program, and you'll also receive today's presentation and additional resources. Next week, we are coming back to our mental wellness series. Physical touch and intimacy are powerful. They strengthen our bonds with the relationships that we have. They increase our feel-good hormones. It lowers our blood pressure and influences how we see ourselves. In the context of romantic relationships, people often associate sex with intimacy. However, intimacy takes many forms, and like everything else in a relationship, intimacy evolves as people change and new challenges arise. So join us to learn how others are navigating intimacy changes and challenges during this candid and virtual conversation next Wellness Wednesday. You can learn more about our PD Health at Home programs, which includes Mindfulness Mondays and Fitness Fridays, by visiting our website at parkinson.org/PD Health. And a local kind of spotlight for a program, if you are in the Tennessee, Kentucky area and looking to connect in person. The Tennessee, Kentucky Chapter Symposium is being hosted in person and online in Murfreesboro, Tennessee on March 4th. You can learn more about the event titled Ask the Expert, Nutrition and Pharmacy by visiting the webpage at parkinson.org/Murfreesboro. If you had a question today that was not answered, please reach out to our helpline by calling 1-800-4PD-INFO or emailing helpline@parkinson.org. You can use that same contact info to order our free resources, educational book series, and other hospital safety kits. So please take some time that you need as a care partner or person living with Parkinson's or someone working in the field of Parkinson's disease. We're here to help you. So thank you all for your time, and I will see you at our next PD Health at Home event. Be well.